بسم الله الرحمن الرحيم. اليوم هنتكلم على اللنج tumor. We divided the lung tumor into benign and malignant. And the malignant tumor divided into primary and secondary. Firstly, we talk about the benign neoplasm. Benign neoplasm of the lung are uncommon, represent for less than 1% of all pulmonary tumors. At times, most are hematoma, fibroma, leiomyoma, neurofibroma, and myeloblastoma. Where is the site of benign neoplasm of lung? Most lesions are peripheral and asymptomatic, no symptoms. Access central lesion can produce symptoms: cough, wheezing, hemoptysis, and recurrent pneumonia. How are diagnosed the benign neoplasm? Typically, the lesions are discovered on routine chest radiography and appear as 1 to 2 cm with circumscribed, pixelated lower lung nodule with calcification from 10 to 30%. Central lesion may require bronchoscopy for biopsy. Fine needle aspiration biopsy under guiding ultrasound or surgery. Treatment of the benign neoplasm of lung. Surgical treatment. Surgical resection should be conservative and limited to wedge excision, except في حالة واحدة إذا كان الليجن occupy the proximal bronchial airway and is associated with recurrent distal infection or bronchiectasis. In such cases, lobectomy is indicated. Following resection, the prognosis is excellent. Malignant neoplasm of lung. في primary and secondary lung cancer. Primary lung cancer include squamous cell carcinoma, adenocarcinoma, small carcinoma, large cell carcinoma, and adenosquamous tumor. Secondary lung cancer أو pulmonary metastasis organ. ده بيجي لللنج من أماكن أخرى. Pulmonary metastasis may arise from the malignant tumor. وين المalignant tumor? Especially common in hypernephroma in kidney. And hypernephroma in kidney, but are especially common hypernephroma, melanoma, osteosarcoma, bone, carcinoma of the thyroid, breast cancer, prostate. كل هذا تعمل secondary deposit لوين لللنج. Gross appearance. There are usually small, multiple, bilateral, and sometimes large and rounded cannonball, طلقة المدفع, تشبه طلقة المدفع, and occasionally central deposit near the hilum that simulate bronchogenic carcinoma. Symptoms of the secondary lung cancer or pulmonary metastasis. Most patients with pulmonary metastasis are asymptomatic. ما في symptom. Even with extensive disease. If symptoms do develop, cough, hemoptysis, fever, dyspnea, and pain are common. Then, the most common symptoms, if developed in the secondary lung cancer, include cough, hemoptysis, fever, dyspnea, and pain are common. Or diagnosis: secondary lung cancer. Routine chest radiography هيبين لنا ايش كانون طلقات المدفع وطلقات مدفع. CT scan are the most sensitive, detecting the nodule as small as 3 ملي. They are also specific. False positive rate 55 than plain X-ray. Fine needle aspiration under guiding is useful for peripheral lesion and not for central lesion. Central lesion, it's better bronchoscopy for tissue diagnosis. إذا الdiagnosis routine chest radiography. اثنين CT scan are more sensitive. ممكن يوضح لنا أي نوديول حجمها يصل إلى 3 ملم. They are also specific. False positive rate of 55% than plain X-ray. Fine needle aspiration cytology is useful in the peripheral lesion. بينما بالcentral lesion may require bronchoscopy for tissue diagnosis. Treatment secondary lung cancer. Medically fit patient في حالة أن المريض قادر يتحمل عملية with resectable disease or surgical, it is the best management. But following the criteria are fulfilled. إذا استوفى هذه الكريتيريا ممكن نعمل resectable tumor. The primary tumor must be controlled. No other site of the disease may exist. No other therapy can over. The operative risk must be low. Primary lung cancer. Bronchogenic carcinoma. Etiology, incidence, middle-aged and elderly. 90% of cases occur between the age of 40 and 80 years. Cancer of the lung is much more common in males than females, and NSBA from the 10 to 1. What are the risk factors? Excessive cigarette smoking. اثنين, inhalation of irritants such as silica, cobalt, dust mines, غبار المناجم, and petrol fumes in large city, نيكل وكروميوم. ده الأهم أشياء من الانهاليشن irritants such as silica and cobalt, dust in mines في المناجم, غبار المناجم, and petrol fumes in large cities, nickel, arsenic, and chromium. Pathology of bronchogenic carcinoma. عندما نتكلم عن الباثولوجي في أي تيومر يجب أن نتكلم على الإيج، ويجب أن نتكلم على السكس والإنسيدنس most common in male or female، ونتكلم على الجروس تايب أو microscopic appearance والميكروسكوبيك appearance والسايت. بالنسبة للبرونكوجينيك كارسينوما جروس تايب although the hilar type is the commonest variety يمثل represent 75%. It arises in one of the main bronchi من البرونكاي الأساسية or other primary division and leads to the bronchial obstruction with secondary chink in the lung. ما هي الchink الذي حتحدث باللنج نتيجة الobstruction؟ يا أما atelectasis يا أما pneumonia or lung abscess. The peripheral type represent 25% right from the smaller and remains asymptomatic for long time. This type include Bankos tumor, which arise in the apex of the lung and invaded the brachial plexus with sympathetic trunk, causing Horner syndrome and the first rib. إذن البريفرال ما يدي لناش أي symptoms. السنترال تايب أو الهايلر تايب هذا هتجيب لنا symptoms نتيجة الأوبستريكشن للمين برونكاي أو ديفيجن. ونتيجة البرونكيال obstruction with the secondary lung change in the lungs such as atelectasis, pneumonia or lung abscess. In the periphery, represent 25% rise from the smaller bronchi and remains as symptoms for long time. ما يعطيناش أعراض لفترة طويلة جدا. This type include واحدة منهم البانكوس tumor. Rise in the apex of the lung. ما زال rise in the apex of the lung. إذن هيعمل لي invaded للبريكيال plexus والsympathetic trunk causing Horner syndrome and first rib. تكلمنا قبل كده على السكلينيس تراينجل. بالسكلينيس تراينجل كنت نتحقق لنا بريكيال بلاكسس وعندنا أيضا arteries وعندنا الإيبكس أوف ذا لانج إيبكس أوف ذا لانج ومعها الفرست ريب. الإيبكس أوف ذا لانج إذا حدث عندنا تيومر فيها إذا هيعمل إيش؟ هيعمل لنا invaded للبريكيال بلاكسس والسمباثيك ترانك causing Horner syndrome. What are the histology of the bronchogenic carcinoma? أول واحدة squamous cell carcinoma represent 60%. Is composed from the irregular ringed squamous cell. Auto cell carcinoma represent 30%. And differentiated small cell with a very scanty fibrous stroma. ثالث حاجة الذي هو adenocarcinoma represent 10% is composed from the columnar cell arranged in irregular acini or papillary formation. It is the commonest in female. It's commoner in female. إذن عندنا squamous cell carcinoma represent 60%, 60%, autocell carcinoma represent 30%, and adenocarcinoma represent 10%. Spread of the bronchogenic carcinoma يا أما direct مثل أي تيومر بثلاث طرق direct lymphatic and blood. إذن direct to the mediastinum, pleura, chest wall and pericardium. Lymphatic to the hilar lymph node, and then to the trachobronchial and lower deep cervical lymph node. Blood mainly to the liver, adrenal gland, brain and bone. من ضمن الباثولوجي عندما نتكلم عن الباثولوجي وفاني تيومر ضروري نتكلم على الستيجنج سيستم أو clinical staging system. The clinical staging system of the bronchogenic carcinoma according to TNM classification, where is the T, the primary tumor and the size, N, it is the lymph node, M, a distant metastasis. TX tumor is proved by presence of malignant cell in bronchopulmonary secretion, but is not visualized on radiography or bronchoscopy. إذن TX only malignant cell cytological bronchopulmonary secretion. T1, T0 no evidence of primary tumor. ما فيش أي حاجة تثبت إن هناك primary tumor. 2 TIS carcinoma inside. T1 tumor about 3 cm. T1A tumor 2 cm in the size. T1B tumor من 2 إلى 3 cm in size. إذن T1 tumor that is 3 cm. هنقسم T1 إلى T1A و T1B. إذن T1A tumor 2 cm in the size. تي بي التيومر من 2 إلى 3 سنتي in size. T2 تيومر السايز من 3 سنتي from 3 سنتي to 7 سنتيمتر in greatest dimension. وهذا نقسمه أيضا إلى T2A تيومر from 3 to 5 سنتيمتر in size، أو T2B تيومر من 5 سنتيمتر إلى 7 سنتيمتر in size. T3 tumor 7 centimeter in size, or one of that directly invade into the chest wall. إذن يحجمه 7 سنتي بالسايز في T3، أو invade أو منتشر into the chest wall including superior sulcus tumor للdiaphragm، للmediastinal pleura، للparietal pericardium، للphrenic nerve, or tumor in the main bronchus from bronchus 2 cm from the carina without involving the carina. Also any associated athleticis يعمل obstruction ويؤدي لنا إلى athleticis pneumonia ولنج abscess أيضا. T4 tumor of any size more than 7 cm size and invasion of the mediastinum or involving للheart للgreat vessels subclavian artery, internal jugular vein, trachea, esophagus, vertebral body, and carina, in addition to stellate tumor nodules that occur within the different ipsilateral lobe. إذا النجول في اللوب الآخر، وهذا في اللوب إذا كان في الرايت هتلاقي أيضا نجول في الليفت. تكلمنا على السايز of the tumor. الآن نتكلم على الليمف نود، على nodal involvement. N0 no demonstrated metastasis to the regional lymph node. N1 metastasis to the lymph node in the pre-bronchial or ipsilateral hilar region or both. N2 metastasis to the ipsilateral mediastinum lymph node and subcranial lymph node. N3 metastasis to the contralateral mediastinal lymph node, contralateral hilar lymph node, and ipsilateral or contralateral squamous or supraclavicular lymph node. M. Distant metastasis. M0 no unknown of metastasis. M1 نقسمه إلى M1A و M1B. M1A separate tumor in contralateral lobe, tumor with the pleural nodules or malignant pleural effusion. MB distant metastasis. The clinical feature of the bronchogenic carcinoma. The bronchogenic carcinoma, it manifests itself by one of the following 5 syndromes. Firstly, insidious type, acute type, Bankers tumor, latent type. خامس حاجة الذي extra pulmonary manifestation أو extra pulmonary syndrome. Insidious, in the most cases the onset is insidious with the dry irritant cup, often ascribed to smoking, which later become asthmatic and associated with the hemoptysis, dyspnea, and chest pain. Acute type, sometimes the onset is acute with the symptoms of pneumonia, which will to resolve satisfactory or relapses within few days or weeks. ما بيستجيبش لأي علاج، وهذا من العلاجات. Bankers tumor, this is the peripheral tumor. تكلمنا وقلنا أنه ممكن يعمل لنا إيش؟ invading the brachial plexus and sympathetic trunk and the upper rib, reducing the lower brachial plexus lesion with Horner syndrome and erosion of the upper 2 إلى 3 ribs. The fourth of the clinical manifestation of the bronchogenic carcinoma is latent type. هذا يحصل بالperipheral carcinoma. The disease may still silent and until discovered by mass radiography or may produce vague general symptoms, fatigue, indigestion, until distant metastasis or symptoms of the mediastinal invasion appear. Distant deposit may produce manifestation of the high intracranial tension. عندما يحدث سبريد للبرين وهذا يجيب لي ايش increase للhigh intracranial tension, headache, vomiting, and pathological fracture, jaundice, and adrenal failure. The five manifestation of the bronchogenic carcinoma extrapulmonary non-metastatic type. Undifferentiated tumor, particularly of the autocell type, may produce hormone-like substance, toxins, or antigens, which produce variety of manifestation, which collectively called the paraneoplastic syndrome. إذن عندنا extra pulmonary non-metastatic type ومن ضمنها الأوتوسيل type. الأوتوسيل type of the bronchogenic carcinoma هتفرز لي substance like hormone like substance, وتفرز toxin, وتفرز antigens, which produce variety of manifestation, which collectively يسموها paraneoplastic syndrome. The paraneoplastic syndrome in bronchogenic carcinoma include Cushing-like syndrome due to adrenal cortical trophic hormone production, which differ from the classical syndrome by an older age incidence, greater frequency in males, and more rapid clinical course. Water retention due to secretion of antidiuretic hormone, substance like antidiuretic hormone, which may result hyponatremia and water intoxication. Hypercalcemia caused by parathormone like polypeptide. Tender gynecomastia due to ectopic gonadotrophin secretion. Carcinoid syndrome due to secrete 5-hydroxytryptamine or hydroxytryptophan. Malignant neuromyopathy, which probably result from release of antibodies to antigen derived from the tumor. These antibodies may cause myasthenia, dermatomyositis, and peripheral neuritis. آخر حاجة pulmonary osteoarthropathy may occur even in the small, حتى لو كان small tumor or small asymptomatic cancer. It's characterized by the sudden onset clapping fingers, sometimes associated with edema, and swelling of the small joint and hands. Investigation firstly الذي هو بلان X-ray أو chest X-ray. هيوضح لنا الكون shadow or hilar obesity or sign of obstructive emphysema, ascites, pneumonia or lung abscess. الصورة هذا تورينا multiple cannon ball. هذا secondary جاي من وين هذا؟ primary site are breast or kidney, sarcoma, testis, prostate or thyroid. CT scan accurately localize the tumor and detect the mediastinal lymph node enlargement. For peripheral lesion, CT scan أيضا ممكن under guiding نأخذ needle biopsy provide high accuracy. بالصورة هذا خلينا نشوف إيش paratracheal lymphadenopathy on the computerized tomography. ثالث حاجة من الإيميجينج الذي هو بازوترون إيميجن توموغرافي routinely used to assess the primary tumor and the mediastinal lymph nodes and to screen or metastasis disease. Bronchoscopy usually establishes the diagnosis and allows the assessment of the operability. In about 60% of cases, the tumor is visible as a nodular necrotic mass or an irregular stenosis, and we can take biopsy for histopathology. What are the signs of inoperability include left recurrent laryngeal nerve paralysis, يجيله المريض بهورسنس, conversion of the trachea or widening of the carina by enlarged lymph node, fixity of the affected bronchus or malignant infiltration beyond the proximal centimeter of the main bronchus. Mediastinoscopy, 2 biopsy nodes of the paratracheal group. Cytology and histological investigation. Sputum. Cytology may reveal the presence of the malignant cell. Splenoid biopsy may confirm the diagnosis and assess the operability. Needle biopsy of peripheral lesion under radiography control will reveal malignant cell in about 60% of cases. Treatment of bronchogenic carcinoma. Surgical treatment. Pulmonary resection, such as lobotomy or extended lobotomy or pneumotomy. It is a ministry of curative therapy for early stage of bronchogenic carcinoma. Regional lymphadenectomy is routinely performed primary or as prognostic rather than therapeutic. Lobotomy used in disease localized in one lobe. Then a lobotomy used in disease localized to one lobe. Extended resection and pneumonectomy used when the tumor involves a fissure or central located tumor. عندنا peripheral وعندنا central. إذا extended resection and pneumonectomy used when the tumor involves fissure or centrally located. With resection or bronchi segmenectomy, يأخذ one bronchi only, might be used in localized disease in high-risk patient. Adjuvant therapy أو العلاج المساعد. More treatment using radiotherapy, chemotherapy, or the both. Might be used post-operative adjuvant chemotherapy or pre-operative adjuvant chemotherapy. Post-operative adjuvant chemotherapy now indicated in the all resected non-small cell lung cancer patient stage 1B and higher, demonstrating small but statistically significant survival benefit. Pre-operative chemotherapy and radiation therapy can be given pre-operative to select patient with stage 3A into disease to sterilize the mediastinal node disease. Differential diagnosis of a mass in the neck. Midline swelling, solid swelling, submental lymph node enlargement, nodule in the isthmus of the thyroid gland, cystic swelling, called abscess, dermoid cyst, thyroglosal cyst, subhyoid bursitis, and laryngocele and cystoadenoma of the thyroid isthmus. Then solid swelling, submental lymph node enlargement, nodule in the isthmus of the thyroid gland, cystic swelling called abscess, dermoid cyst, sublingual or suprasternal, thyroglosal cyst أيضا subhyoid bursitis laryngeal and cystoadenoma of the thyroid gland. Epidemiology in adult in case of mass in the neck. Role of ET. ET of non-thyroid mass in adult are neoplastic. ET of neoplastic mass are malignant. ET of malignant mass are metastatic. ET of malignance in adult are squamous cell carcinoma. ET of metastasis are from the primary above the clavicle. 80% of parotid mass are benign. 80% of the minor salivary mass are malignant. Risk factor: tobacco, smoking, alcohol, HIV, and barrier to the malignancy. Post-operative pulmonary complication. It's very important. دائما ينزل في الامتحانات. What are the predisposing factors for post-operative pulmonary complication؟ في عندنا pre-operative وفي عندنا operative. إذا بالpre-operative predisposing factor age of the patient, extreme age, are more liable to complication. Extreme age on old age or in young age. 6 male are more predisposed to respiratory problem than female, probably due to smoking. Heavy smoker have chronic bronchitis. Dehydration, this leads to the thick bronchial mucus that is difficult to expel. تعمل obstruction في البرونكاي يتحول إلى atelectasis أو pneumonia or lung abscess. Operative predisposing factor: anesthesia, trauma to the trachobronchial tear, pre-medication with atropine, and prolonged unconsciousness predisposed to the respiratory problem. Nature of the operation: thoracic and upper abdominal are more liable complication, as the wound pain interfere with the deep breathing and coughing. Post-operative predisposing factor: إذا كان عندنا pre-operative و-operative intra-operative وفي عندنا post-operative. Predisposing factor to post-pulmonary complication: abdominal distension due to paralytic ileus interfere with the movement of the diaphragm and reduce the vital capacity in the lung. Post-operative pain interfere with the deep breathing and cough, leading to stagnation of secretion. Excessive use of narcotic also interfere with the deep breathing and cough. Type of pulmonary complication: atelectasis, bronchitis, bronchopneumonia, lung abscess, pulmonary embolism, Mendelssohn syndrome, adult respiratory distress syndrome, and post-operative hypoxia. The first complication from the post-operative pulmonary complication, it's atelectasis, post-operative atelectasis, أو بعض الأحيان يسموه pulmonary collapse. What are the predisposing factors? Inhalation of foreign bodies or vomiting due to full stomach. Production of the mucus due to pre-operative respiratory tract infection and pre-medication with atropine or post-operative dehydration. Inhibition of the cough reflex due to old age and depleting patient. Excessive sedation, particularly with the morphine. Operation on the chest, diaphragm or upper abdomen. هيعمل limitation للmovement of the diaphragm. هيعمل decrease للvital capacity of the lung. البين lack of mobility in bed, morbid obesity, recent stroke, pathology of pulmonary collapse or of atelectasis, consequence of complete airway obstruction, هي obstruction of in the bronchi and subsegmental bronchi or bronchioles. هيعمل prevent the air from reaching to the alveoli. هيعمل resorption of the air trapped in the distal air space through the pores of cone. هيعمل leak in the air distal to the air space. هيعمل deflation ويعمل collapse. What are the causes of obstruction? يا أما mucus يا أما mucopurulent يا أما flowing surgery aspiration from body material bronchial asthma bronchitis bronchiectasis كل هذا ممكن يعمل لي cause للobstruction. Clinical features of pulmonary collapse or atelectasis. In typical case, the onset is sudden with fever, in addition to dyspnea, cyanosis, and chest pain in massive case. Cough is slightly, and sputum is scanty and difficult to expel. The condition might subside after few days with expectoration of large amount of the purulent mucus. As signs, unexplained tachycardia, a minor atelectasis produce no local sign. لكن في حالة الcollapse, major collapse, the segment or all the lung that the affected side of the chest is flattened, immobile with dullness on percussion, diminished breath sound on the affected side, and displacement of the trachea and the heart towards the side of the collapse. As the attack subside, tubular breathing and cross crepitation may be impaired. Chest X-ray of atelectasis or pulmonary collapse of the left lung. هذا بالإكسري ما تبقى الذي الأسهم هذه تشير إلى ما تبقى من اللنج. أما هذه المنطقة كلها كولابس. هنشوف بالرايت لانج هذا الرايت هذا الليفت لانج هذا الرايت لانج هنا ما فيش أي كولابس وهذا. إذن the collapse lobe appear as homogeneous wedge-shaped obesity. اثنين major cause approximation of frame and elevation of the diaphragm and deviation of the mediastinum toward the affected side. Treatment of pulmonary collapse or atelectasis. تكلمنا أن في predisposing factor pre-operative و intra-operative. إذن prophylaxis. Pre-operative prophylaxis. إذن stop of the smoking, deep abdominal breathing and coughing. Post-operative prophylaxis incentive spirometer. Minimize use of depressed drugs, good pain control. Treatment, clearing the airway by chest percussion, coughing and nasotracheal section. Bronchodilator and mucolytic agent gives by the nebulizer might help the patient with the severe chronic obstructive pulmonary disease. Atelectasis from the obstruction of the major airway may require intrabronchial section through endoscopy. This procedure that can usually be performed at the bedside with mild sedation for patient. Pulmonary embolism account for 30% of hospital inpatient death, and treated has mortality of 30%. Treated mortality reduced to about 2%. Only 10% have clinical sign of deep venous thrombosis. Risk factor: operation, mobility, vessels injury, hypercoagulable status, low protein C and S, congestive heart failure, obesity, age and old age, pregnancy, and polycythemia vera. Clinical presentation of pulmonary embolism. عندنا symptoms وعندنا sign. الsymptoms: dyspnea, pleuritic chest pain, hemoptysis. A sign: low-grade fever or pyrexia, central cyanosis, tachycardia, tachypnea, hypotension, neck vein distension, pleural rub, and increase in pulmonary second sound. Then symptoms: dyspnea, pleuritic chest pain, hemoptysis. A sign: low grade of pyrexia, central cyanosis, tachycardia, tachypnea, hypotension, and neck vein distension, pleural rib, and increased pulmonary second sound. Investigation used in pulmonary embolism: arterial blood gases, hypoxia, decrease the oxygen in the blood PO2 tension يسموه, and hypercarbia وزيادة في CO2 but sometimes may be normal. ECG sign of right heart string classical S1 Q3 T3. S1 wave in the lead 1, Q wave in the lead 3, and inverted T wave in lead 3. Chest X-ray oligemic and central pulmonary marking and exclude the other pathogenesis. Ventilation على perfusion scanning may confirm the diagnosis. Pulmonary angiography and echocardiography useful if hemodynamic instability. useful في حالة hemodynamic instability. ثاني حاجة spiral CT scan replace بعض الأحيان نستخدمه بدل البلمونري angiography. lower limb investigation to exclude the DVT. Management of pulmonary embolism. It's depend on the degree of suspicion and hemodynamic stability. Then, if high degree of suspicion but stable patient, نبدأ نعطي anticoagulant with heparin or low molecular weight heparin, oxygen analgesic colloid to increase the central venous pressure, warfarin for at least 3 months. هذا إذا كان if high degree of suspicion but stable patient هذا. طيب if hemodynamic unstable, consider pulmonary thrombolysis by pulmonary arterial catheter. If the thrombolysis contraindicated, consider نتحول إلى pulmonary embolectomy. رابع شيء inferior vena cava filter inserted percutaneous usually via femoral vein, present at physical barrier to emboli. Indicated if recurrent pulmonary emboli despite adequate anticoagulation, excessive proximal venous thrombosis and anticoagulation is contraindicated. The third complication of the post-operative pulmonary complication, pulmonary aspiration. What are the mechanisms which preventing of aspiration? Aspiration of the oropharyngeal. ممكن الاسبيريشن من الاوروفارyngeal and aspiration ممكن من الgastric content is normally prevented by gastroesophageal and pharyngoesophageal sphincter. What are the factors predisposing or predisposed to aspiration? Insertion of the nasogastric tube and endotracheal tube. Depression of the central nervous system by drugs interfere with the deafness and predispose aspiration. Other factors such as gastroesophageal reflex, food in the stomach, or position of the patient might play a role. Trauma victims are particularly like to aspirate regurgitation gastric content when consciousness is depressed. Patient with the intestinal obstruction, pregnant women who have increased intra-abdominal pressure and decreased gastric motility are also high risk for aspiration. Pulmonary injury or trauma from aspiration depend on many factors. Volume aspirated, كمية الvolume pH is very important. If the aspiration has pH أقل من 2.5 or less, it causes immediately chemical pneumonitis, which result in local edema and inflammation that increase the risk of secondary infection. Frequency aspiration of the solid matter can produce obstruction of the distal bronchi will tolerated initially can lead to the athleticis and pulmonary abscess formation. What are the clinical manifestations of pulmonary aspiration? Tachypnea, rales, hypoxia are usually present within hours. Less frequently, cyanosis, wheezing, and apnea may appear. In patients with the massive aspiration, hypovolemia caused by excessive fluid and colloid loss into injured lung may lead to the hypotension and shock. Treatment of pulmonary aspiration. Aspiration can be prevented by preoperative fasting, proper position of the patient, and carefully intubation and a single dose of proton pump inhibitor. A treatment of aspiration involves re-establishing the patency of the airway and preventing more damage to the lung. Endotracheal section should be performed immediately, as this produces confirm the diagnosis and simulate coughing, which help to clear the airway. Bronchoscopy في حالة solid material. Fluid resuscitation should be undertaken. Antibiotics are used usually when aspirate is heavily contaminated. They are used to later to treat the pneumonia. Adult respiratory distress syndrome sometimes يسموه shock lung. هنتكلم بصورة مختصرة لأنه في سنة رابعة وخمسة نتكلم عليها بصورة يعني أوسع من cause of respiratory failure, hypoxemic failure type 1 يسموه. إذن في حالة الهايبوكسيميك فيلير في reduced للبي سي او 2 و reduced للبي او 2 أيضا. إذن reduced لثاني أكسيد الكربون و reduced أيضا للأكسجين. هذا نسميه hypoxemic failure or type 1. ventilatory failure type 2 increased BCO2 للثاني أكسيد وريديوس للأكسجين. What are the cause of the hypoxemic failure and ventilatory failure؟ نمسك أول شيء ventilatory failure. decrease للماشين في حالة إيش؟ chronic obstructive pulmonary disease and chest trauma، أو respiratory depression في حالة الدرجز تراوما ورجد للانتراكرينيال بريشر. الدرجز the most common drugs الذي يعمل لديبريشن هي السنتر والمورفين. تراوما رجد للانتراكرينيال سباينال كورد ليجن، cervical spinal trauma and motor neuron trauma، peripheral neuropathy، myasthenia gravis. ثاني حاجة muscle relaxant. إذا هذا الكوز of the ventilatory failure. إذا دي arranged للماشينز هذا في حالة إيش؟ هذا في حالة الكرونيك obstructive pulmonary disease وفي حالة الشيست تراوما. respiratory depression يا أما نتيجة درج for example morphine or trauma or rise للانتراكرينيال بريشر، أو نتيجة spinal cord lesion cervical spinal trauma وmotor neuron disease، peripheral neuropathy، myasthenia gravis and muscle relaxant. نشوف الهايبوكسيميك فيلير الذي هو تايب 1. هذا متى يحدث؟ هذا في حالة الكولابس consolidation لهذا contusion pulmonary edema and pulmonary embolism أو embolus. إذن الهايبوكسيميك فيلير الذي فيه هيكون CO2 reduce CO2 وريديوس O2. الكوز collapse، ثاني حاجة consolidation contusion pulmonary edema and pulmonary embolism أو embolus. Clinical manifestation of acute respiratory distress syndrome include dyspnea, cyanosis, evidence of obstructive lung disease, pulmonary edema, unexplained decrease in BO2. Earliest manifestation tachypnea, hypoxemia, وincrease the respiratory rate. Hypoxemia may initially present with confusion على delirium. التريتمنت oxygen by mask، pulmonary toilet clear secretion from the airway. ثاني حاجة bronchodilator. treatment of acute respiratory insufficiency يحتاج sometimes إلى intubation and ventilation, mechanical ventilation. If this measure fails to keep oxygen saturation at 16 mmHg, acute respiratory distress syndrome considered acute respiratory distress syndrome. Control of the post-operative pain can decrease the pulmonary complication. Post-operative hypoxia. What are the causes of the post-operative hypoxia؟ يا إما leak of alveolar ventilation أو leak في alveolar perfusion. hypoventilation في حالة الايروي obstruction أو في حالة جبناها للمريض درجز وبيت for example المورفين، برونكوسباز، نيموثوركس، arteriovenous shunt هيعمل لنا collapse and atelectasis. ليك بالالفولار perfusion ventilation على البرفيوجن مس ماتش pulmonary embolism في حالة البلمونري impaired cardiac output decrease للالفولار diffusion pneumonia and pulmonary edema. كل هذه العوامل تؤدي إلى post operative hypoxia. diaphragmatic hernia تعرف as it's the herniation of abdominal content through the diaphragm into the chest. Classification عندنا two types, congenital وacquired. الcongenital منها four types. إذا congenital four types. الacquired three types. أول حاجة بالcongenital hernia through the foramen Bronchogenic, anterior between the xiphoid and costal margin, through the foramen Bronchogenic, the pleuroperitoneal canal lying posteriorly. إذا through the foramen of Bronchogenic هذا anterior يكون. Through the foramen of Bronchogenic في pleuroperitoneal canal lying posteriorly. Through the deficiency of all central tendon of the diaphragm, such as hernia, might be traumatic in organ. Through the congenital large esophageal hiatus. Acquired hernia يسموها hiatus hernia. فيها ثلاث أنواع. Sliding hernia 90% تمثل herniation of the both stomach and the gastroesophageal junction into the thorax. إذا sliding hernia 90% الكومنست. rolling hernia تمثل أقل من 10% but it's dangerous. وهذا dangerous لأنه من الكومبليكيشن حقها ممكن يعمل لي strangulation and gangrene for stomach. وهذا ثالث حاجة الذي combined من type 1 and type 3. إذن sliding hernia 90% 90% herniation of the both stomach and gastroesophageal junction. لا الثوراسيك. rolling hernia أقل. herniation of all or part of the stomach through the esophageal hiatus into the thoracic with indisciplined gastroesophageal junction. إذن هنا ما فيش أي تغيير للجاستروإسوفيجيال جانكشن في حالة الرولينج. في حالة السلايدنج لا، ده جزء من الاستومك مع الجاستروإسوفيجيال جانكشن وين يروح للتشيست. كومبايند من الثالث حاجة combination of type 1 and type 2. Etiology of congenital diaphragmatic hernia might be genetic, might be decreased lung fluid pressure, failure of closure pleuroperitoneal canal, foramen Bronchogenic. هذا هو الفورامين التي موضح بالصورة. Early return of bowel into the peritoneal cavity from the physiological hernia. Eventuation, it is weakening of the diaphragm due to atrophy and loss of the muscle of a part muscle, جزء من المصل بالdiaphragm or all one of the left diaphragm أو من الdiaphragm with the thin fibrous tissue formation covered with the pleura and the peritoneum on the other side. Classification of eventuation يا أما congenital or acquired. Congenital marked decrease in the muscle fibers in the diaphragm. Clinically, it might be mimic congenital diaphragmatic hernia with sac. Acquired يا أما نتيجة phrenic nerve paralysis، واللي احنا عارفين ان البرينيك nerve supply للdiaphragm، أو نتيجة viral usually in adults poliomyelitis أو herpes zoster, influenza, diphtheria, neoplasm or iatrogenic. Presentation of eventuation. Most of them present in the infancy and childhood. Few of them might be escaped to adulthood. Might be present no symptoms, asymptomatic. أو ممكن يجينا في wheezing, recurrent lower respiratory tract infection, extreme exercise intolerance, extreme respiratory distress, أو Symptomatic patients have functional deficit in ventilation على perfusion ratio because the lung group is affected. Diagnosis of ventilation by chest X-ray, CT scan, MRI shows the abnormality. This picture shows the ventilation of the diaphragm. Ventilation of the diaphragm. Differential diagnosis of ventilation. Diaphragmatic hernia through foramen bacterial. Condition cause respiratory impairment. Treatment usually surgery. What are the indications for surgery? Symptomatic patient. Decreased ventilation على perfusion ratio. Prolonged more than 3 to 6 months exertional dyspnea. Impairing delay activity in idiopathic, viral or pharynx nerve palsy. A treatment is plication of the diaphragm through laparotomy. النوع الثاني من الهرنيا اللي هو traumatic diaphragmatic hernia. هذا يحدث either in the right or left, resulting from the road traffic accident or crash أو penetrating injury or blunt injury. Patient is under shock. On the right side, along the liver, the intestine might also get herniated. إذا ممكن الانتستين herniated to the chest. The patient is pale, present with respiratory distress, guarding and rigidity over the abdomen. Investigation X-ray chest هتشوف عند abdomen هتشوف ايه؟ هتشوف البول in the chest. لو عملت سكولتيشن هتسمع البول sound أيضا in the chest. Ultrasound الabdomen open CT scan of the abdomen and chest is done. التريتمنت المريض جاي لنا بشوك. إذا firstly resuscitation and immediately laparotomy and exploration is done. Tear in the diaphragm is sutured. إذا التير الذي بالdiaphragm should be sutured نخيطه. Associated injury in the liver or spleen or bowel are treated accordingly. إذا لما نعمل exploration laboratory don't forget انك تشوف الليفر تشوف السبلين تشوف البول ايضا والكل. اذا في perforation هذا ضروري according to ضروري management. Adequate blood transfusion if need and antibiotic is required. Ventilatory support is often necessary. إذا التريتمنت of traumatic diaphragmatic hernia المريض هيوصل لنا في شوك. إذا هنبدأ نعمل resuscitation and immediately laparotomy. بعد ما يصبح stable نعمل laparotomy. هذا وأثناء نعمل laparotomy ضروري تعمل exploration laparotomy. تشوف الليفر تشوف السبلين and bowel ونعمل تريتد لأي واحد منهم. بس اللي نركز عليه الليفر first degree و second degree no need surgical intervention. أيضا في السبلين first degree و second degree no need surgical intervention. Adequately blood transfusion if need and antibiotic. Ventilatory support is often necessary. تكلمنا على الإيفنتريشن والكوز اوف إيفنتريشن وقلنا انه نتيجة ويكنس للدايفراغم لبارت من الدايفراغم أو لف من الدايفراغم جزء من الدايفراغم هذا. وتكلمنا على الكونجينيتال دايفراغماتيك هيرنيا وقلنا ان الباكديلك دايفراغماتيك هيرنيا it is most common. وهذا ايوه 80% من الكونجينيتال هيرنيا عبارة عن باكديلك. 80% in the right and the left side. وهذا in the left side 15% in the right side و5 may be bilateral. إذن الأتيولوجي increase the intra-abdominal pressure as in pregnancy, obesity, or wearing tight corsests. Decrease the elasticity of the right crus as in obesity and old age. إذن أي كوز يعمل لي increase للانترا abdominal pressure يعتبر predisposing factor for hiatus hernia. Classification of hiatus hernia. Hiatus hernia are classified according to the position of the gastroesophageal junction in relation to the diaphragm. In relation to the diaphragm, at type. Sliding hernia, it is the commonest hiatus hernia. 90% of hiatus hernia. Isolation, herniation of the both stomach and gastroesophageal junction into the thorax. إذن الستومك and gastroesophageal junction هيعمل لي herniation into the thorax. A rolling hernia represents 10%. Herniation of all parts of the stomach through the esophageal hiatus into the thorax with an undisplaced gastroesophageal junction. إذن بالsliding hernia الستومك والجاستروesophageal junction كلهم displacement للثوراسيك. بالرولينج هيرنيا لا، النسبة حقها 10%، والذي يحدث ايش؟ يحدث الستومك جزء herniation of all or part من الستومك لوين through the esophageal hiatus into the thoracic with undisplaced or displacement of the gastroesophageal junction. التايب الثالث اللي هو combined، الذي combination of type 1 and type 2. أيهما أخطر؟ it is the rolling hernia، it is dangerous هذا، لأنه يصير فيها strangulation ممكن gangreenous ليش؟ للسtomach. This picture showing the three types of the hiatus hernia. Firstly, sliding hernia اللي هنشوفنا في الصورة هذا gastroesophageal junction، وهذا الدايفراغم، وهذا الستومك herniated stomach، وهذا الاسوفيجاس. إذا بالسلايدنج هيرنيا هذا gastroesophageal junction displacement of the thoracic، وأيضا معها الستومك. نجي نشوف التايب الثاني، وهذا الذي هو الرولينج. وهذا الرولينج لا، الجاسترواسوفيجيال هذا هو الجاسترواسوفيجيال جانكشن، ويحصل هرنيشن للستومك، بينما الجاسترواسوفيجيال جانكشن ديسبليس. ثاني حاجة كومبايند من التوت من فيرست تايب اند سكند تايب. وقلنا ان الخطيرة فيها هي الرولينج هيرنيا. ليش الرولينج هيرنيا؟ لانه الانسيدنس اوف strangulation and gangrenous هذا هاي، فيري هاي، ولذلك دائما نقول ان الرولينج هيرنيا تحتاج الى mandatory operation، تحتاج الى operation not conservative treatment. ممكن sliding hernia conservative treatment، لكن rolling hernia no، it is surgical management. picture of hiatus hernia هنقسمها إلى typical symptoms و atypical symptoms. إذن في symptoms typically نقول عليها هذا من البرزنتيشن حق hiatus hernia. وفي atypical symptoms نشوف typical symptoms. The typical symptoms of gastroesophageal reflux هيجي لنا بايش؟ بهارت بيرن، regurgitation and dysphagia، typically triad. إذن الثلاثة الترايد هذا الهارت بين regurgitation and dysphagia نسميها typical triad of symptomatic typical symptomatic of hiatus hernia. Other symptoms include water brush and odonophagia. Symptoms are aggravated by botchal They're like plaque binding and stopping them, and can be severe, especially at the night after the large meals. Atypical symptoms reflex may sometimes present with some atypical manifestation, as chest pain simulating coronary artery disease. يعني should be differentiated من coronary arterial disease. Pulmonary manifestation simulating bronchial asthma. Laryngeal manifestation as present by coughing in the voice or choking. Rarely, the patient may present with anemia or hematemesis in case of the severe esophageal erosion. Differential diagnosis of hiatus hernia: cholelithiasis, diverticulitis, peptic ulcer, achalasia, myocardial infarction, angina, pancreatitis, gastroesophageal reflux, and gastritis or pericarditis. How do you investigation of hiatus hernia? Gastroscopy with biopsy, document type and the extent of the tissue damage, roll out of the esophagitis or Barrett's esophagus and cancer. إيش هي Barrett's esophagus؟ تحول السكوما cell of the lower part of the esophagus to the columnar cell، وهذه واحدة من predisposing factor of the esophageal cancer. ثاني investigation 24-hour esophageal pH monitoring, often used if typical presentation gives information about frequency and duration of the acid reflux. ثالث حاجة esophageal manometry, detect decrease lower esophageal sphincter pressure, may also diagnose motility disorder. Upper gastrointestinal serious barium swallow. نأخذ عدة X-ray complication of hiatus hernia: reflux esophagitis, chronic occult blood loss with anemia, ulceration, dysphagia, esophageal stricture, Barrett's esophagitis الذي adenoc aspiration pneumonia and strangulation في حالة rolling or mixed type الذي من type 1 and type 2. Treatment of sliding hernia: usually conservative treatment. في حالات معينة ممكن نعمل ممكن تكون indication for surgery. الكونسرفاتيف تأخذ الستوب اوف سموكينج، الويت لوس، elevate للهيد اوف ذا بيد، no nocturnal meals. ثالث حاجة small and more frequent avoid للالكحول coffee and fat. ميديكال الذي هو الانتي اسيد و اتش تي انتجونست او بروتين انهبيتور. هنضيف لها adjuvant prokinetic agent may be play a role، مثل ايش؟ الميتوكلوروبروميد الذي هو البلازيل والموتيليوم. هذا هيعمل ايش؟ هيزيد لي الموتيليتي اوف ذا stomach. conservative treatment نأتي للسيرجيكال تريتمنت. أقل less than 50% indication for management by surgery. Indication for surgery أول حاجة complications sliding hernia or GERD, especially stricture, severe ulceration, fibrosis, bleeding, and Barrett's. Symptoms refractory to conservative and medical treatment. يعني relief أعطيناها conservative treatment والميديكال الذي هو البروتين بامب والذي هو الميتاكلوروبروميد، وبعدها تحسن المريض وبعد فترة عادت له نفس السيمبتومز. يعني failure للميديكال treatment. What are the type of the surgery؟ نيسان funduplication، هذا بيستخدموا يا اما open يا اما laparoscopic where the fundus of the stomach is warped يغلف around the lower esophageal sphincter and surrounded in the place. إذا احنا قلنا في بداية الكلام انه displacement للجاسترو اسوفيجيال جانكشن ومع الستومك هذا. إذا من أجل أثبت الجاسترو اسوفيجيال جانكشن عمل نيسان فاندبليكيشن الذي يا إما باللابروسكوب where the fundus of the stomach is warped يغطي around the lower esophageal، أما هو موضح في الصورة هذه. 90% success rate. Treatment of paraesophageal hiatus hernia. Surgery in almost every case to prevent severe complication الذي هو الجنجرينس. Thank you for you.